So thank you, ma'am, for your wonderful talk. I am Dr. Ankur from Raipur AIMS. And in this era where we are talking about positivity, where we're talking about people to be more and more independent, I have been giving a talk by Chairman ARC about not to do something by the residents. What we are trying to emphasize from ages is that to make our residents more and more proficient, but what I'm going to highlight just few points is that what not to be done. So when I started my PG program, we were initially afraid to touch the patient, and gradually our consultants, our professor, our heads allow us to see the patients, allow us to develop that confidence. When we went on doing our fellowship days, the first thing is that we were dealing with a lot of patients, and we were always into it that we need to do more, learn more and more to decide to make the factors. But at the completion of a fellowship, that is during the last 3 or 4 days at 3 or 4 months at Arvind, what we really learned is what not to do with the patients. What not to do, which surgeries you have to say no. The final decision is what not to do. So that is what I'm going to talk about. My topic is performing A and B scan by residents. Starting with the A scan biometry. Currently the optical biometry is the gold standard, and now we are moving on to the OCT based biometers. But still there are many centers in India, especially the government setups, or more to add to the condition, the private medical college, they still rely on ultrasound biometry, the immersion type and the contact type. So in such situations, the A scan, the keratometry has to be done manually. And the common mistakes commits by the resident is taking the manual K readings. Even if they take them manually correctly, there is at times difficulty in entering them correctly into the biometer machine. So that is a difficult part, and that has to be taken care of. The second important point is that in cases of contact tonometry, like if we do an immersion tonometry, it's good, but if you do an contact tonometry, then there's always a chances of excessive corneal compression out of hesitancy, out of not knowing the procedure, and of course it changes the axial length and the final IOL power. So this is second important point which has to be kept in mind while the residents are doing it. The third is that they don't have a clear-cut idea about which IOL power has to be used in extremes of the axial length. Like when you talk about normal axial length, it's great, but when you talk about the myopes or hypermetropes, the formula changes. And this is also not there in minds of the residents. The wrong selection of A constant, that is the A constant which is imprinted on IOL, they generally put that they don't know what is the personalized A constant or what is the A constant which is readily available on ULIP. So these are the common mistakes which is done by residents while they are doing the A scan. So another point is that the residents in many centers, they are in a sort of hurry. 100 patients from the camp have come and they have to do biometry of all the patients. So they are in a sort of hurry, and hurry anywhere commits mistakes. The second thing is the different users. If 2 residents are on night duty, one takes comfortably the charge of doing the keratometry, while the second takes the charge of putting the readings and doing biometry. And there comes the biggest cause of error. Not considering the readings of the fellow eye, for example, different axial length, different K values, is another important point which have to be kept by residents in mind while performing the A scan biometry. And of course, it is for us that we are not analyzing the outcomes. So on the B scan, as madam talked about the choroidal melanomas, yes, it is very important, but the limits of the things can always be missed. The residents do not have a clear-cut idea about the pathology, how far the pathology extends, and they can miss on the extent, and hence the planning changes accordingly. The probe orientation may be long. The wrong measurement of the extent of the lesions I have just talked about. For example, in the cases of orbital cysticercosis, they might miss upon the few findings. So lack of knowledge also endangers the machine. This also has to be kept in mind. The probe itself is very expensive. So what I want to emphasize by today's talk is that in this world, we have to train our residents. We cannot produce a future generation of ophthalmologists or the second generation without that. But as Prakash Marathe sir has told in the morning, that they have to be done under supervision and not free-handedly. Thank you so much.